So this is a 37 years old male who is not a known case of any risk factor in hypertension, diabetes, nothing, no smoker, no tobacco cheer, and no history of any heart disease or any history of CAD in the family member, in parents or brother sister. And he presented 3 days back. He presented with sort of atypical pain. So I did the drop eye and echo, and it was normal. ECG was absolutely normal. There was nothing. So I sent this patient and I put him on the routine medications, and then after 3 days he came back with telling typical anginal pain on and then I did angio, and this is the picture. You see how bad this coronary artery of this young patient, 37 years old male. Now he presented with the ST depression in the anterior lead in the ECG and normal LV function, and you see this is the angiogram of this young patient who has no risk factor at all. Homocysteine was normal, no vasculitis, nothing, and he is a vegetarian even then. And this is the angiogram, and you can see the LM is normal, and this is the ileocaudal view, and you can see there's a total occlusions of the LCX, and this right from the ostium there is a occlusion, 95% occlusion stenosis in the ramus or high OM, and you can see the LAD also, mid LAD there is a lesion, and this is a apicaudal view, and you can see the same thing. There is a total occlusions in the LCX, and probable this is a May CTO. There's some collaterals, and if you see this high OM or ramus, right from the ostium there is a lesion, and there's a multiple tandem lesion. And if you see the ramus, the proximal lesion, proximal region, and LAD, obviously in the proximal LAD there's a 60 to 70% lesion, and the mid LAD will show you in the next view. This is the epicranial view, and you can see the LAD, how bad the LAD is. Right from proximal there's a lesion, and after just diagonal there is a lesion of 80 to 90% stenosis. And if you see this diagonal right from the ostium, osteoproximal lesion is there, long lesion, and there's a tandem lesion in the diagonal, and this is the areocranial view, and see how bad the diagonal is, and then the LAD, mid LAD and proximal LAD. This is a ileocranial view. You can see the diagonal and distal LAD is how bad, multiple tandem lesions are there. And this is a RCA. You can see RCA. You can see the RV branch is very thin RV branch, and if you see in this cranial view, you can see RV branch is thin vessels and multiple lesion is there. And if you see the distal RCA, mid to distal RCA, there is a over 90% lesion in the, and PDA PLVs are small, and that is the angiogram of this 37 years old young patient who don't have any risk factor, homocysteine normal, vasculitic profile normal, coagulation profile normal, no factor 5 mutations, nothing, and with no risk factor. You can see this is the angiogram. So you can see how bad the coronary arteries of this young male, and obviously we have given the CABG for this patient, and we are given the option of multivessel PTCA, but CABG is the first choice, so they agreed for the CABG. And this is the angiogram of this young patient. Kindly post your plan of management for this patient.